Hello, I'm Fernando Guerra, professor of political science and Chicano studies at Loyola Marymount University. I'm also the director of the Center for the Study of Los Angeles. In addition, I am the host for the Urban Lecture Series, the program you are about to view. Here at Loyola Marymount University, we take pride in having our students engaged in the civic dialogue of Los Angeles. We send our students out to the community, but in addition, through this program, we bring the community to Loyola Marymount University. We hope you are informed by today's program. And for more information about Loyola Marymount University, the Center for the Study of Los Angeles, and the Urban Lecture Series, please check out our website at lmu.edu/CSLA. Okay, as we discussed last week when we took a look at education, the Levy Center for the Study of Los Angeles at Loyola Marymount University is undertaking a leadership initiative. We have a lot of public opinion data. The center does this, UCLA, USC, the LA Times, all kinds of private pollsters. We know a lot about what Los Angelinos think, either residents or voters, all kinds of different universes. And we probably do a poll a week on LA residents. When I say we, I mean collectively academia and different public opinion research firms. But we have very little information about what leaders think. As a matter of fact, if you were to do a search on leadership and you put Los Angeles in there, you'd come up with very, very few hits. There is not a single, until now, systematic study of leadership in Los Angeles. It just hasn't been done. Number one is, what is the universe? I think we intuitively, many of us know what a leader is, but trying to define it and who falls into that is problematic. So we've dealt with that issue. What we're trying to do is establish a group of about 1,000 leaders throughout Los Angeles in these different sectors. This is the third sector that we've completed. You saw last week we talked about education, and we didn't talk about it in this class, but the previous semester we talked quite a bit about it in terms of the political sector. So we've interviewed the political leaders, we interviewed the education leaders, we've now interviewed the health leaders. So we have 300 leaders in Los Angeles. At the end of the day, it's an academic exercise because we want to know what leaders think. Compare that to the mass public opinion or the residents of Los Angeles. But we also think that when you try to give direction to the city, there's certainly government and institutions and academics who try to do that. But what we would like to do is bring leadership together. If I were to ask the president of this university and a couple of other presidents to get the leaders together from around LA, they could do that. And they would bring them together one day and they would discuss issues facing Los Angeles. But if we were to ask them to come back the next week or the next month, it would be very difficult. Many of you have heard me say that one of the most difficult things to do in politics or in society is to mobilize people. It's difficult to mobilize people, to mobilize even elites, to mobilize you to get you guys to come up here from the lower campus or to get you to attend class when you have to. Think about mobilizing people from disparate different groups. While that is incredibly, incredibly difficult, 100 times more difficult is sustaining that mobilization. And so sustaining the attention of leaders to continue to focus on issues would be very difficult. So we're going to try to do this in an artificial manner, and that is by contacting them through this survey. And then if an issue comes up that's a very important, that all of a sudden Los Angeles faces, the DWP issue that we talked about last week, or an earthquake, or a report from the federal government regarding illiteracy, or something about all kinds of different issues that can come up. And oftentimes what happens is the public or civic dialogue, the public narrative of that issue gets captured by the media, and typically you go to the far right and the far left, and they dominate the conversation. And oftentimes, so-called leaders in the middle, their voices are not heard. And so what we're going to try to do is, once we have these leaders, is to do what we call an insta-poll, and that is a one-page, 5 or 6 questions. We already have their demographics, we already have their ideological perspective, we already have their income level, what part of the city they live in, et cetera. And we ask them 5 or 6 quick questions about the crisis to try to determine where leadership is at that moment on that crisis. and try to develop a center and a direction to the issue. Well, will we be successful? I don't know, but we're going to try it as what can Loyola Marymount University contribute to the civic dialogue of Los Angeles? This is our attempt to try to do that. And so we are a third of the way through collecting the basic data, and then we'll continue this over the next couple of semesters, okay? There's no magic to 1,000, there's no magic to 100. If we have 101, that's great. If we only have 80, that's okay. But and if somebody says, hey, you've excluded so-and-so who's a great leader in health, he should be included, our response is going to be absolutely give us the information and we'll include him in what we're doing. So in terms of the methodology, we had we surveyed health leaders who impact policy, practice, advocacy, and or research. That means that somehow they either practiced in Los Angeles, somehow they impact the health policies of Los Angeles. So they could actually be residents of Orange County or residents outside the city, but they have their practice or their main focus is in the city of Los Angeles. Okay, and then one of the questions we asked them is how liberal you are. We found not a single conservative in our sample, okay? We all know, many of you in the different classes have been looking at the exit poll data, and you know the overwhelming support that Obama received. I think there only, of all registered voters in the city of Los Angeles, only 20% are Republicans. And so Republicans are decreasing in a rapid rate in Los Angeles, but we also find that amongst the leadership. We're not surprised by these findings that LA's leaders, even in healthcare or other areas, are liberal or even moderately liberal. I am a little bit shocked that not a single one claimed to be a conservative. So but to give you a sense of their ideology. Second, we asked them this question: thinking about healthcare in Los Angeles County, are you generally satisfied or dissatisfied with the quality of the public healthcare system in the county? And you can see that the dissatisfaction is somewhat dissatisfied and very dissatisfied, makes up 75%, 74%. So 3/4 of health professionals in the city of Los Angeles are dissatisfied, some very dissatisfied in terms of the healthcare system. Do you think that Los Angeles County residents would be better off or worse off with a national health care reform? And you can see that the 79% is, it's an impressive figure in terms of the response that we got there. Okay? We have a sheet right here that's got most of that for you. Let's get, John, give one to, you don't have one. We'll get you one right now. Okay, which of these do you think is more important, reducing healthcare costs or increasing the number of Americans who have health insurance? And both equally was the easy answer, so we had 67% that, and about a fifth or 19% increasing the number of Americans who have health insurance, and about 11% reducing the care costs. How much confidence do you have in Barack Obama to do the right thing when it comes to dealing with healthcare reform? Well, obviously, given the ideological leanings of this, it was 81% have some or a great deal of confidence in Barack Obama and his healthcare reform. Who do you trust more to handle major changes in the country's healthcare system, the Democrats in Congress or the Republicans in Congress? And again, you see the ideological partisan leanings of our healthcare elite. Finally, does Los Angeles County have the resources to sponsor its own healthcare reform? When we did the survey, the healthcare reform was going through, but the vote had not yet occurred. We thought it would come out the way it did occur, but we were trying to say if the feds didn't do it, is there anything that the county could do, given its limited resources? Does Los Angeles County have the resources to sponsor its own healthcare reform? And 14% of the respondents believed that it could. But you can see that 43% absolutely not, and 27% said no, but possibly in the future. It just shows you the limited amount of resources that the county has. As many determinants of health lie outside the healthcare system, how important is it that we fund activities that improve health in these areas? And you can see where, in terms of alcoholic dependencies, overweight, smoking cigarettes. Okay. Again, this is on the sheet that we passed out. And the final results, because we're still working on this, we're still actually receiving some responses, will be available in the summer of 2010. You can also go to the website, and if you have real complicated questions, you can ask Bree. But if you want to cite it or quote it, you can cite me. I'm kidding. Okay. Welcome to Loyola Marymount University, the Urban Lecture Series, sponsored by the Levy Center for the Study of Los Angeles, also the Economics Department, the Political Science Department, Chicano Studies, American Cultures, Urban Studies. All these departments have gotten together to sponsor this great lecture series. Also today, much of our research was sponsored by the Kaiser Permanente, so we have to give them a little bit of a shout out. Today we have several individuals who have been intimately involved with healthcare over the years, and I'm going to introduce them to you one by one. And then we're going to ask them also just to very quickly tell us what they're currently doing in terms of their organization, and then what they think about the healthcare reform that just occurred. Right sitting next to me is Howard Mandel. He currently serves on the Board of Trustees of the Johns Hopkins University of Temple Israel of Hollywood, and is on the Board of Directors of the Friends of the Saban Free Clinic here in Los Angeles. He previously served on the boards of Oakwood School, Century City Hospital, Los Angeles Free Clinic, and its Hollywood Endowment Corporation. He is a fellow of the American College of Obstetricians and Gynecologists, and he was chairman of surgery as well as chief of gynecology at Century City Doctors Hospital, and served twice in that role at Century City Hospital. He owns and operates his own private medical practice in Santa Monica. He has served as a volunteer doctor at the Los Angeles Free Clinic, and because he had so much time left in his hands, he was seriously thinking about running for Congress in the 33rd District, Diane Watson's district. He also served as Howard Dean's health advisor during his presidential campaign. And Dr. Mandel holds a BA degree from Johns Hopkins University and MD from the New York University School of Medicine. Next to him is Dr. Raul Ruiz. He currently works as an emergency physician at Eisenhower Medical Center in Rancho Mirage, California, focusing his skills on developing policy to improve public health and healthcare access for vulnerable populations in the Coachella Valley and internationally in the jungles of Chiapas and Mexico. And also, he also was in Haiti during the recent earthquake, responding to that crisis. He also airs on Univision Palm Springs local news, a health show, Vive Más, every Wednesday, informing Spanish-speaking communities about the important health topics. Dr. Ruiz also started a mentorship program for local graduating high school students who want to be physicians. He received the Influential Latino of the Year Award from the Inland Empire Image Award in 2009. He was, as we mentioned earlier, a responder to the victims of the Haiti earthquake in 2010. I think he went there with Sean Penn. He's serving also as a medical director for the Jenkins Penn Haitian Relief Organization. For these efforts, Dr. Ruiz was awarded the Commander's Award for Public Service, a medal given by the U.S. Army 82nd Airborne. You didn't parachute down to Haiti, though. Okay. He completed his undergraduate studies at UCLA before acquiring a medical doctorate at Harvard Medical School, a master's in public policy at the Harvard School of Government. He also specializes in emergency medicine at the University of Pittsburgh Affiliate Residency, and I can just go on and on. I think also you're the first Latino ever to receive 3 masters from Harvard University.
3 graduate degrees.
3 graduate degrees, okay. Next to him, we have Gloria Rodriguez. Ms. Rodriguez began her career in healthcare at age 16 when she became a certified nursing assistant and worked in different branches of healthcare until she discovered community health centers as her preferred practice setting. Currently, Ms. Rodriguez is CEO of the Community Clinic Association of Los Angeles County. It's a membership organization that represents nonprofit community clinics that operate primary care sites throughout Los Angeles County. Prior to her present position, she served for more than 7 years as CEO for the Washington Association of Community and Migrant Health Care Centers. And before joining the staff of that organization, she was Assistant Director for the Department of Labor and Industries, the largest provider of health insurance in the state of Washington. She was also served as Associate Director of CMAR Community Health Centers and was founding CEO of the Alliance for Multicultural Health in Tacoma, Washington. She serves on the board of the California Primary Care Association, the LA Care Health Plan, the Uninsured Project, and a former board member of Los Angeles Area Chamber of Commerce. Again, I can keep reading about all the great accomplishments that she has. She holds a BS degree from San Jose State University and a Master's of Public Health degree from the University of Washington. All right. Next to her is Roger Simon. He is currently chief political columnist for Politico. He's co-founder and CEO of Pajamas Media, a news and opinion media company with correspondents in over 40 countries and studios in Los Angeles, D.C., New York, Denver, Knoxville, and Tel Aviv. Mr. Simon previously served as president of the West Coast branch of Poets, Essayists, and Novelists, or PEN for short, and as a member of the board of directors of the Writers Guild of America. He is author and has written 10 novels, including the prize-winning Moses Wine Detective series, and 6 screenplays, including Enemies, a Love Story, for which he was nominated for an Academy Award in 1989. He's a former faculty member of the American Film Institute and the Sundance Institute. In 2009, he published his first nonfiction book, Blacklisting Myself, Memoirs of a Hollywood Apostate in the Age of Terror. He holds undergraduate degrees from Dartmouth College and is a graduate of the Yale School of Drama. And many of you are probably asking, what's he doing here in terms of this panel? and we'll get to that. And finally, and someone who actually helped me put this panel together is Dr. Peter Weiss. He is co-founder of Rodeo Drive Women's Health Center, which is a full-service facility in Los Angeles dedicated to providing the best care possible for women of all ages. He's become a nationally known figure in women's health, speaking in numerous lectures and television and radio interviews across the country. He's also assistant clinical professor of obstetrics and gynecology at UCLA School of Medicine, and he's been an attending physician at Cedars-Sinai Medical Center for the past 20 years. He was a healthcare advisor to Senator John McCain's presidential campaign, and he received his bachelor degrees from the University of Detroit, another great Jesuit university, and a medical degree from the University of Michigan. He completed his residency at Kaiser Permanente here in Los Angeles. So as you can see, we have a great panel, incredibly well-informed, incredibly into the medical, not theory, but certainly the practice of what has been happening in healthcare in Los Angeles. I'm just going to go down the line a little bit and have Dr. Mandel first start off and talk a little bit about what he's doing right now and what do you think about Obamacare?
I'm honored to be here, and I would call the talk today Deal or No Deal. And the reason for that is, though I think we would argue that the data that was shown earlier demonstrated that we all need as Americans, and specifically Los Angelinos, a change in the current healthcare system. Is this healthcare bill one that is going to help the average American and specifically people in Los Angeles? And I would say that it was imperative that the bill get passed for political purposes, but that in anything that gets passed, there are sometimes winners and sometimes losers. And I will say that specifically Los Angeles as a city and as a county, and if you look at the region around where this great university is situated, which is the congressional district of Maxine Waters, which is the 35th congressional district, that we're going to be a loser. So if you look here in this basin of Los Angeles, we lose big. And the reason for that is what I would say is a problem of leadership and a problem of listening to people who day to day are involved in the practice of healthcare. And what I would advocate as future leaders of our society, that you here taking this class and being involved can have your voices heard only if you raise your hand and only if you get involved. And that's the biggest problem, in that there are generational shifts, and certain generations and certain individuals are heard louder. And unfortunately, our elected officials listen to those people who vote, and people under the age of 30 don't, and certain racial groups vote less than other groups. And with that, those people who don't vote don't get represented.
But doesn't this bill help youngsters in terms of at least that one? Many of our graduating seniors here, as soon as they graduate from Loyola Marymount University, they will have no health insurance.
Correct.
Because they will no longer be covered by the university's health insurance if they signed up for it, and they can't be covered by their parents. This bill allowed them to be covered until they're 26, although it doesn't become effective right away. So that helps this demographic group that's young.
Until you're 26, right. So there's two parts to that. One is that most insurance policies will give you a 3-month grace, so you carried on the policy for another 3 months. September is the magic date when 26-year-olds will, in fact, then be eligible on their parents. However, 3 of the largest insurance companies in America have ruled that they will allow it as of June 1st. So basically, everybody who's been graduating, you'll, for the most part, be safe, as long as you're insured with one of the biggest insurance companies. If not, there's a small window where you might have to purchase an individual policy. Having said that, after 26, and or if your parents are currently not insured and cannot put you on their policy for other reasons, you will actually be charged significantly more to purchase your health insurance than other individuals. And the reason for that is that there is an 800% differential in the real cost of providing health insurance for people who are 64 years old versus people who are 24, 26-year-old. However, because of the world of politics and the way the bill was created, they narrowed that 8-fold difference to 2.7. But they weren't going to charge the people who vote more to pay for themselves. So they get a discount. So if you're 62 or 64 and you go out into the open market to buy health insurance, you actually get a cost-shift discount. And guess who's paying for it? Everybody who's 26 to 28 or 35. All right, that wasn't discussed. And one of the problems I have with this bill, one of the problems I have with the way healthcare reform has gone on, is that the proper discussions and the proper debate that we should have been having were not the ones that we were having and the ones that did occur.
Raul, or Dr. Ruiz, excuse me.
It's okay.
What are you up to right now over at Eisenhower Medical, and how in the world did you end up in Haiti?
Well, that's a very interesting question, how I ended up in Haiti. I don't represent necessarily an organization per se. Eisenhower Medical Center is a nonprofit in the Coachella Valley. I'm an ER doc, and I'm an advocate for my patients, and I'm an advocate for the communities that find themselves vulnerable and oftentimes left out in a healthcare system that don't have access to care, and therefore they come into the emergency department at their last whims. In terms of Obamacare, I can tell you as an advocate for the community and for the poor what the patients are saying. 2 days ago, I saw a woman who came in with a breast lump to the emergency room because she was frightened that it was cancer and she's had discharge from her nipple. Sure enough, she had a mass, and it's quite possibly that she may have a certain type of tumor. I see patients who come in with depression and anxiety because they lost their jobs and they lost their insurance. I see diabetics who have gone without their medications because they can't afford it, so therefore they are coming in with a very severe disease called diabetic ketoacidosis, and they get admitted to the ICU.
By the way, that's going to be on the final exam.
Yeah. So I believe that Obamacare, or this healthcare reform that passed, will cover, what do they say, the estimates are 32 million people. However, there are, I believe they say 16 million still left out of the system. The healthcare reform should be titled health insurance reform primarily. And we know that healthcare access is much more than just healthcare insurance. in the location where I work and where I live, and actually where I grew up. I come from a migrant farm worker community. My parents worked in the fields, and so the communities I serve is the ones that I grew up in and that I hold very dear to my heart and that I advocate for. The situation there is, and one that the health insurance reform does not address, is the lack of physicians that go to these areas. Yes, there is a lack of doctors in certain communities and certain communities of poverty, but it's not only the quantity, but it's the distribution of the physician and the services that's also important. For example, in my home area, there is one physician per 3,000 population. And the World Health Organization recommends in developing countries one physician per 1,000 population. There are trailer parks in the area with a population of 6,000 people that live in conditions that are worse in developing countries. So one of the things that this healthcare reform leaves out, unfortunately as well, is the undocumented populations. There is no answer to that at this point. And that we need to address, because if we're going to work as leaders and to provide the healthcare advocacy that we need for human beings and take a humanitarian approach to relieve suffering of our populations and improve what we need to improve in order to have a better community health, then we need to address that. The other thing is, I believe we need to not have silo thinking. And every one of us are very much really involved in our careers. For example, law, urban planning, medicine, education, and what have you. But if you look at community health and the health of our populations, you will realize that the determinants of health oftentimes involve education, opportunities, job employment. So as leaders in our respective fields, we need to expand the model, expand the paradigm of what it means to promote community health. So that's another point I want to make. And in areas of poor resources, one of the things that we should focus on, because we really don't know what the implementation is going to be of the healthcare reform or how it's going to look like, and there's still a lot of opportunities to maneuver and bringing in the implementers of any policy to measure the outcome or to determine what is actually going to be produced. But one of the things in resource poor settings that we need to look into is regional models of cooperation, where we have shared resources, not only funds, but ideas of transportation, for example, and getting to the hospital for low-income patients, and also health education. I give free health talks in the poorest of neighborhoods out in the open, called People's Health Talks, and we talk about health issues that pertain to the community and at the same time organize the community around health issues. The other thing I do is go on TV every Wednesday to talk about health issues that pertain to the communities that are in that catchment area and Spanish speaking and also low income, and determine how income is a risk factor for poor health, or I should say low income is a risk factor for poor health. So, and that's one of the lessons that I brought back from Haiti.
Okay, well, how'd you get to Haiti?
Well,
I don't mean physically. I mean, how did you end up?
It was very interesting. I was in Washington, D.C., working with the census and trying to promote the census, and we were we were having a tour of the Capitol, and so we bumped into Congressman Kucinich, who eventually there was an introduction that was made, and so we met in his office. And we talked about Haiti, and at that point he realized I have a master's in public health from Harvard that focused on humanitarian disaster aid. And so his friend, Sean Penn, was developing a team to enter Haiti. And so that was where the connection was made and the introductions were made. And 3 days later, we're in Haiti. And in the first 3 weeks there, my responsibility was to manage the physicians, the healthcare providers, and the supplies. We were able to bring in 100,000 pounds of supplies and disperse them to the most needed locations, and have over 800 patient encounters through our healthcare providers in different hospitals, camps, and locations that are not even formed into camps, with the assistance of the 82nd Airborne providing the logistics.
Okay. Ms. Rodriguez, explain to the students your organization, community clinics or free clinics, and then the impact that this legislation is going to have on the type of organizations that you represent.
Thank you for having me. I'm very happy to be talking to all of you tonight. Our organization is represents 45, can you hear me? 45 community clinics, which include free clinics, that operate 135, actually now a little more, actual clinic sites throughout the county of Los Angeles. Community health centers are organizations that provide primary care, which is medical care for basically birth to death, all age groups, without regard for income or insurance status or residency status. We provide services on a sliding fee scale, but we are also, many of the clinics are federally funded, and others, like the Saban clinic, is a free clinic, and that's one of our members. These clinics are what is known in this county and probably most places, the safety net. We are part of the safety net. And the patients that we serve, over 90% of them have incomes below 100% of the poverty level. So we're talking the poorest of the poor. With the recent recession, we have definitely seen an increase in the number of people coming through our doors. It's not unusual for the patients to start lining up 2 hours before the clinic even opens. We have had to expand our hours. We have traditionally been open Mondays through Saturdays from 8 a.m. to 7 p.m., but we now have many clinics operating on Sundays and operating till 9 p.m., depending on the safety of the location, and trying to add more providers as we can. The demand is overwhelming. Right now, there are approximately 3 million uninsured people living in Los Angeles County. And
So
our
wait a minute,
clinics
so there's 10 million people that live in LA County, so you're saying 3 million, that's 30%.
are uninsured. And we serve through our clinics about 1 million. So there's 2 million out there that are basically forced to use the emergency room or go without actual healthcare services. Obamacare will be very helpful to our patients because, as I said, the majority of them are under 100% of poverty level. And the increased access to Medicaid, and in this state, Medi-Cal, would be under 133% of poverty. So a large number of our patients would now be covered, which would be very helpful, of course. However, we do serve a number of undocumented folks, so we would continue to see those patients. The difficulty will be in getting specialty care services and then ultimately hospital services for those patients. But basically, it's the same problem we have right now for any of our uninsured patients. That's always the difficulty, is access to specialty care services and access to hospitalization. In this county, we use the county hospital system, but there are parts of this county where there isn't a county hospital located in what I will call a reasonable travel distance. For instance, if you live on this side of the county, you would have to either go south to Harbor UCLA or downtown to County USC, or up to Sylmar for all of you. So your options require quite a distance.
So Obamacare gives more resources to free clinics, or how does that?
Well, it doesn't give resources, not to free clinics. Not to free clinics. Yes.
So, okay, what is a free clinic?
What?
A free clinic means that anybody who walks in, there's no charge for the services, or there's charge to the degree that they can pay, or does it vary from free clinic to free clinic?
A free clinic, a pure, what I'll call a pure free clinic, does not charge the patient, but they will charge public programs and participate in public programs. Community clinics, however, also participate in those public programs. but charge on a sliding fee scale based on the patient's ability to pay. Then there are federally funded clinics who get a federal grant which helps to subsidize that care. So that's what helps subsidize the sliding fee scale.
Okay, so it's a combination of public money, donations, and...
Absolutely, a lot of fundraising.
Okay.
And then your question about whether or not Obamacare would help.
Mhm.
There are $11 billion set aside to establish more and fund more community health centers. So many community clinics who are not currently federally funded, as well as free clinics, could now apply to become federally funded. And new organizations could also start up. So yes, there would be growth of community clinics. We don't know how much money would go to currently existing community health centers. But Obamacare also helps because you would now have a fund source.
Mhm.
You know, for many of your patients where, you know, they can't afford to pay anything and you're having to raise money, they'd now be covered through Medi-Cal, or even some of them who work for small businesses. Those small businesses may now start insurance programs, so they may have insurance through their small businesses. That will be a resource, because otherwise, where you did not have a source of income for the patients you're serving, a reimbursement source, you would now have a reimbursement source. So it is a win on two fronts.
Okay. Roger Simon, novelist, writes screenplay, Academy Award nominee. What are you doing on this panel?
Dr. Weiss invited me. In part, he invited me because I run a media company that's been covering this for some time. So I have a very different perspective on this, on the debate. Part of the things we did was we got Dr. Weiss to do a program on the company. But I'd like to point out two things. One is that there will always be a healthcare crisis, and there has always been a healthcare crisis. And there's some very good news about it, though. That if everyone in this room were a student in 1935, your life expectancy is, I don't know, 15 years less than it is today. So something has gone on that's very good. And we have to acknowledge that and start from that. And I'd like to address the second thing, which is what Dr. Mandel brought up. We had virtually no serious debate of the current health care legislation that went through. At least I wasn't aware of it. The American public wasn't very aware of it either.
Well, there was a lot of talk.
What?
There was a lot of talk about it.
Yeah, a lot of talk about it, but there wasn't a serious, it became instantly politicized in a way something like this should not be politicized. And what happened was that the public felt, and I think many of you are aware of this, that I think the statistics were close to 70% of the people were opposed to the healthcare legislation when it was enacted. Now, this is not necessarily a bad thing, but it's not a good thing. Because it sets up a populace that's sort of going, to a whole new program and setting up a show me thing. There was not very much honesty from politicians on either side of the political spectrum. Now, I speak of someone who does not like ideology. So when I see that the graph up there of so and so is a Republican, so and so is a Democrat, I go, whoa. And as a test, and this is a scientific matter, medicine, not a political matter. And I want to ask this room one question. This is a pop quiz. How many here, raise your hand, know where the terms left and right come from? One man. Let me ask you, should I ask you what it is? Where do they come from? Absolutely right. They come from where the people in the French Assemblée sat in 1789. So my message to you from that is, get over it. It's a hell of a long time ago. And now it's start to address facts on the ground. And one of the facts on the ground, having lived, I lived a long time in the UK. And when I lived in the UK, I lived under a completely one-payer socialized medicine system, which had some good things and had some dreadful things. Getting to see the doctor took a long time. And that's a reality that people, you know, who on the left are all about this thing, don't want to face. It is not simple. There are no simple solutions because everybody wants medical care, everybody in this room, and there's limited resources. And that's what the American Republic was, they're going, whoa, because we're living in very desperate times. They're very, not great times now. So people were like, wanted more public discussion. Now, that doesn't mean what these people said isn't true, and there are good aspects of these things. I applaud those aspects, and the time we'll see in the days to come how many of them work, how many don't.
Well, let me
But
take
the
a
truth of the
step.
matter is,
Let
from
me
the
take
pic-
a step back so that
we
you can
didn't-
contextualize for the students. What is Pajamas Media?
Pajamas Media is an online media company that reports news and opinion. So
Okay.
that's it. I mean, like Huffington Post and others. You know, we all have our perspectives. We have our perspective. So that's what.
But there's
it
no
is.
ideological perspective.
Oh, certainly there is. It's more.
Oh, so you
center-right.
guys, you haven't gotten over it then either, left or right.
Well, my personal perspective, people want to know. I'm all over the map on different issues. So, but
It's kind of like an essay that I read on the midterm, all over the map. So I'm used to that.
So I'm very free market and I'm very pro gay marriage. I mean, it's like different sides.
So how, when you, as CEO of Pajamas Media, and you're trying to, because this is the new media, as you're
Right.
trying to present this to your audience,
Mhm.
how are you trying to position it, and
Well,
how?
I should pass the table here to Dr. Weiss because he was one of the major people in that. What we did was we invited largely, and Dr. Mandel was on there too, doctors and other health practitioners to discuss it and bat this thing around. You know, in our limited way, we're only one slice of the pie. What happened, and I believe, and this is not just our company, this is the larger picture, is that this thing became so politicized, it got pushed through so quickly, that there are a lot of things that didn't get worked out. I mean, this is as I said at the beginning, that's why I said there'll always be a healthcare crisis, and there always will, because there'll always be more people needing doctors, and then there aren't going to be doctors there to do it. I mean, that's just real. I mean, you live that probably every day. So no matter who pays for it or how, there's always going to be a problem. Anyway,
Dr. Weiss, you were healthcare advisor to Senator McCain, assuming that Senator McCain had won the election. What would have been healthcare reform under President McCain?
Boy, that would have been a nice one to see. I'm going to answer that, but I want to back up just a moment. The one thing that's really great, and you guys take note of this, always try and go last, because you get to hear what everyone else has to say,
Well,
and then you can become a
they're-
politician and
They're used to
answer it
that. They always
accordingly.
try to sit way in the back, so it's not.
That's right. I used to sit in
They
the
already
back
have
with-
that lesson. They've already learned that lesson.
But let me answer that in a back way. Listening to all of you speak, and I said, boy, you're making good points. I hear what you're saying, but I kept writing down the primary problem each time. And it comes down, you remember, any of you take your real estate courses, they tell you it's location, location, location. And in healthcare, it's the cost, the cost, the cost. And I wrote a policy book that got a lot of play that I'm not sure if it's good or bad, but I was praised from Bill Maher on the left and Bill Crystal on the right, all in the same policy paper, so I have no idea what I wrote because it makes no sense then. But the bottom line is the real problem with healthcare system that we have is the cost. And I will propose to you, if cost were not the issue, there wouldn't be a problem. So cost is the real issue, and that's what we have to address. And Obamacare, and I'm afraid I'm going to call it no Obamacare, as much as it does try and do good, it does it in such a costly manner that you could have done it for a lot less. And I'll come back to where the policy that McCain had weren't all good. They didn't listen to everything I said, and they didn't listen to a lot. But the bottom line is we have to do the cost. So when you take a look at the cost with Obamacare, it was, like Roger said, it was so politicized. It's not a $940 billion plan. They take $500 billion, the Medicare cuts, put it into a different plan, add it on, that's $1.4 billion, and when you really take a look at taking 10 years of revenues for 6 years of service, which really comes out to about a $2.8 trillion healthcare plan, of which we don't have the money to do it. You remember nobody's going to admit that they ever watched a beauty contestant show, but when they always say, and I would like world peace. I would like world peace too, but it's just, you have to deal with the reality. In medicine, we deal with reality. So one of the things we have to take a look at, it's really the cost. We have to address the cost and how are we going to pay for it. If we don't have the money, you don't have the services. All you guys out here, the 37 million Americans who don't have health insurance, which is truly a problem. About 40% of that are the 18 to 34-year-olds who, not that they couldn't afford health insurance, they didn't want to pay. I remember being 18, I thought I would live forever. I didn't need an insurance that was basically what you guys are going to be doing now when your insurance comes up. You're going to be paying for us old farts, all due respect there. For us, you don't need to have insurance for prostate cancer. You don't need to have insurance for long-term care, but we have to make you pay for it because there's no money.
Well, but
So
that's
we're
not
forced-
unusual. I mean, many of us pay taxes for other purposes, and many of us who are well off don't need services, but we constantly pay for that.
So what we're trying to do is find, no, that's a good point, but we're trying to find ways to pay for things that we don't necessarily have, but we need to acknowledge that what we're doing. What I don't like is the politicization from both the left and the right, and I got that from when I was as an advisor, from the same thing, what we can do politically, what makes sense. So getting back to what we have about the health insurance, about why I don't think Obamacare is going to be successful, is because we're going to end up paying for it in the long run. The emergency rooms is an example for Dr. Weiss, which is phenomenal. These emergency room doctors are incredible. They do a lot more life-saving work than I ever will do. And my hat's off to you for doing all that in Haiti and everything. But there was a recent study that showed 84% of those that go to emergency rooms do have insurance. It's 16% that don't. All right. That's still a lot. Who are those who go to the emergency room? 20 to 25% who go to utilize emergency rooms are for non-urgent cares. All right? So what we're saying that if you had insurance, you would go to your doctor. But right now, even those who have insurance are not going to the doctor because they don't want to wait 2 weeks. We're Americans. We don't want anything tomorrow. We want it today. So if somebody has minor aches and pains, they're going to come to you. I worked in the HMO system for 6 years. I worked emergency rooms. I would have patients that would come in the middle of the night. Why? Because they didn't want to wait 3 months or 2 months to see a doctor. They wanted to take care of it now. They had to work. So there's a lot of issues that we have to address. Going all the way around back to what you asked originally, when I said it's about the cost. There's another aspect of this healthcare bill that it did not address. Not one iota was towards tort reform. Now, tort reform, as physicians that we can tell you, it's not the 2 to 4% that President Obama claims is the healthcare cost for malpractice insurance. That's just malpractice insurance. We practice defensive medicine. I've reported between 9 to 25%, depending on how you look at those numbers, of what we do and the healthcare dollars is spent on defensive medicine and defensive
Well,
documentation.
define defensive medicine. for the
Defensive medicine,
students.
it's a very good point. So defensive medicine means that you come up to me or you come into me and you have a chest pain. And Dr. Ruiz is the very good doctor who sees you. He said, boy, this really sounds like heartburn. Take a Tums, take a Pepsid, let's see what happens. But he can't do that. He now has to do, even in his very good clinical judgment, thinks that that's all that it is going to spend thousands upon thousands of dollars to do a complete cardiac workup to make sure it's not a myocardial infarct, heart attack. You have a young kid who comes in.
Now, of course, if I'm the one that walked in there and he thinks I need a Tums, I want that $1,000.
But who's going to pay for it? So you've got a young person that comes in, faints and not faints, it just hits his head against the door, bangs his head. The kids in the dorms are goofing around. Go to an emergency room. You examine him. Dr. Mandel, the gynecologist, is the one who's now in the emergency room seeing you with your head injury. This is going to be really good. He's now going to take a look at you, and if he has in his clinical judgment going to think, listen, I think it's nothing, let's watch it, is one thing. But defensive medicine will now dictate that you have to get a CAT scan or MRI. I'll even go further. In the United States, we have roughly 6 nurses per patient, 6 to 8 nurses per patient. In Europe, it's 6 to 8 patients per nurse. In Europe, it's roughly 12 patients per nurse. It's not that we have such a better system or that we're working harder, is that half of the time, if you go to a hospital, half of the time, the nurse is documenting, writing down the chart. Dr. Ruiz, how much time are you spending documenting what you're doing in the emergency room instead of taking care of patients, or Dr. Mandel? So these are all things that have to be taken into account. If I can try and quickly summarize when you went back, what would a healthcare look at now? There are certain things in the Obamacare that actually make sense. Absolutely it does, but you don't need to spend $2.8 trillion to accomplish what you needed to do. Dr. Ruiz mentioned health insurance reform. Absolutely is needed. The pre-existing conditions, all these other things that we need to do. But what happens when you go to an insurance system like this where you say, yes, the 30 million more will go on Medicaid, there aren't any doctors that are going to take Medicaid. You think it's a waiting time now of 2 months to see a doctor? It's going to be 4 to 5 months. There's a lot of things that are in this thing that just don't make sense, and it could have been done a lot better if, as Roger said, there would have been true dialogue. And the right is just as guilty as the left. So this is, yes, is it something that's moving forward, but not necessarily in a good point. The one thing that McCain had that I think made sense was actually trying to acknowledge that we had to have insurance reform. There was one proposal that we had about affinity groups being allowed to obtain insurances from members of Costco or AAA or a church to be able to buy insurances as groups, and people will be able to get it. And because of ERISA laws, or certain laws which say that you cannot be denied because of the pre-existing conditions. I had a proposal out there for trying to increase number of physicians, where they didn't like, but it was basically saying that instead of going through medical school and college 8 years and paying all these years, you make it straight from high school, 6-year programs. They do have these type of programs. And it should basically for free. And in return for these physicians who are trained, give 2 to 3 years back to the country in underserved areas. Actually, McCain actually liked that idea. And there's so many things that we can do. So while it might have been the best of intentions, it's going to fall flat and short. We don't have the money.
So, Dr. Mandel?
Yeah, it's kind of interesting because everybody brings out great points. So let's talk about a couple of them. One is the bill itself. There's going to be 1 million nurses short by 2016. Do we really address the nursing shortage in the Obama bill? No, we don't. We should have, but we were debating other things. So we need to fix that. Ongoing, we need to fix that. In regards to community clinics, so there are different kinds of community clinics. There are free clinics, community clinics, and there's the federally qualified health centers. But the lobbyists for the federally qualified health centers want to keep all the cookies for themselves. So the other kinds of clinics didn't get money for capital. They didn't get money for medical information technology. They didn't get money so that they could hire physicians who want to work in underserved communities and pay off their loans. Because the other groups wanted to keep all the money for themselves. So now we're going to have organizations and certain communities, like the ones in Los Angeles, are not going to be eligible to get some of those funds. Dr. Ruiz pointed out some good points about the fact that in parts of California, there's only 1 physician for 3,000 patients. Well, if you kind of look at the Medicaid population, which is in California, is called Medi-Cal. Currently, there's 46 doctors per 100,000 patients. So prior to the bill, there were 7.5 million people in California on Medi-Cal. Now, there's 2 million extra. So there's 9.5 million people on Medi-Cal. There are no new doctors taking Medi-Cal. So instead of 46 per 1,000, that number is now dropped statewide to more like 33 or 34%, which is basically the one in 3,000. So we took a problem, and with the new bill, we actually made it worse. If somebody goes to the emergency room where Dr. Ruiz works, he and the nurses and the hospital gets paid from the state of California about 19 cents on the dollar that gets billed. So what happens? Sooner or later, small emergency rooms are not going to be affording to pay their rent. They're not going to be able to pay their nurses. They're not going to be able to pay for their supplies. So the small emergency rooms are going to go belly up, and the larger ones are going to get more cost shifted. So let's kind of look at your population of students here. LMU is a great school. 75% of the students at LMU are on scholarship and some form of financial aid. So there's a cost shift, and that tuition gets shifted a little tiny bit from the people who are wealthy or her parents have resources, and it's been cost shifted to help all of us have a global community here, which is really nice. So let's look at healthcare. This bill takes, instead of 25% cost shift, it goes to 2% of the population instead, and gets the cost shift from them for basically the other 98%. Economically, that just cannot work, and it will not work. It is a economic impossibility.
So how, on a practical level, does this bill impact what you do as a doctor, as being on this free clinic? How will it change what you're going to do starting next year?
Well, unfortunately, there's two separate issues. One is the free clinic. My belief is the free clinic is no longer going to be free. My belief that, unfortunately,
So we're going to have to change the name, almost free clinic.
it's going to be not free at all, clinic. I think what's going to happen is that because of the bill and the way the bill is set up, is that the free clinic is going to no longer become a free clinic and is going to switch to become a federally qualified health center, in which case they can get the pool of money, which then mandates by law that they have to bill patients. So if you look at the last year that the numbers were available, in 2007, there were 718,000 patient visits in the federally qualified health centers in Los Angeles. There's 42 clinics, 123 different sites. 716,000 patients seen in federally qualified health centers that had to bill people that were poor. The federal government says you've got to bill people and you've got to chase them for money even if they can't afford it. And less than 2% of all the revenues of all those clinics were from those patients. And it cost 3 to 4% to get it. Now, I run a small business, okay? You don't charge people for things that's going to cost you more money than you collect. You think about it here. I mean, sometimes it just pays to give it away for free. The whole concept of the free clinic movement in America was when people are too poor, you give it away for free. You don't force people to try to pay you and try to get 3 cents from them when it costs you $1.50 to collect it. It's the same thing when you go to any single Starbucks, okay? If it's 3 cents extra, they have a little pool of pennies there. I mean, what is that all about? So the fact of the matter is we need good business practices, and this bill doesn't encourage that at all. And then lastly, Dr. Weiss talked about tort reform. There's 2 paragraphs in a 2,400-page bill on tort reform. They wouldn't discuss it at all, and that's related to the economics of political fundraising, that the 3rd largest donor to the Democratic Party is the American Trial Lawyers Association. And I think we have
So in other words, trial lawyers who sue people want to keep suing people so they can make money.
Correct. And you see them on the buses everywhere, 1888. If you're at home in the afternoon watching TV shows, you see, do you have anybody with lung cancer, mesothelioma, call us at this 800 number. Basically, the same concept happens in healthcare, and it has a major, major big difference. Let me give you an example that you might all relate to. We were talking about this a little time bit earlier. How many people went to Coachella over the weekend or knew somebody who went to Coachella? All right? Yeah,
Really?
good. Yeah. So 75,000 people.
We purposely don't have papers due
Yeah.
the week after
Right,
Coachella.
which is called it's being smart as a professor. So 75,000 people went to Coachella, right? And it was hot in Coachella. And sometimes you get a little dizzy, right? So let's say...
I don't think it's because of the weather.
All right, so let's say you're dizzy, not because of the weather, and you've taken some substance, and you go to an emergency room. Now, I don't know about Eisenhower, where Dr. Ruiz works, but JFK Medical Center has a rule that if you enter the emergency room with an altered mental status, okay, and I don't know exactly, but if there's 75,000 people at Coachella, let's say 50,000 had an altered mental status, okay, if you were taken to an emergency room, the rule of the hospital is you must get a CAT scan. You must. $2,000 test for an altered mental status in JFK Medical Center, okay? Now let's say you had done some extravagant altered mental status, and you
Is
did
that
it-
a medical term?
Yeah.
Extravagant altered status?
Yeah.
Okay.
So let's say
High-priced drugs.
you did X, you dropped some acid, or some really strong
So
hash
you were raised in the 60s, right?
in Brooklyn, right? So let's say you did one of those mind-altering substances and you were taken in, and you didn't want to have that done. It would be forced against you, and if you fought them, they would then give you sedatives
More substance.
and
Yeah.
tie you down to have a test you don't need and potentially couldn't pay for. Now, if you had insurance, they'd bill your insurance company. If you didn't have insurance, who would pay for that? That would then be charged to the state of California through the tobacco tax. That is the problem of why we need to have a healthy debate about what we're really doing. Do we need to do everything doctors do? The answer is no. Do we need to do everything nurses do? The answer is no. And that money doesn't disappear. One of the great matriarchs of the free clinic, Mimi West, used to say, free ain't cheap.
Yeah. So let me get Peter and then Raul to respond.
Yeah, I just want to make one comment. It's very, very well said, Howie. There are recent studies that have shown, we're talking about defensive medicine again, what we doctors are feel that we're forced to do because whether right or wrong, we're paranoid about the trial lawyers on, like vultures on the wire hanging over our head. Did Woody Allen say about just because you're paranoid doesn't mean somebody's not after you? Something like that. But
Paranoid is someone who knows all the facts.
it works. But there was an interesting study that roughly it was felt that 1/3 of all CAT scans done in the United States were done for defensive medicine purposes, meaning you really didn't need it. 1/3. All right, let's take this further. Now, it's also been proposed that roughly 1 to 1.5% of cancers in the next decade will be a direct result of the unnecessary radiation from those CAT scans. So not only is defensive medicine an immediate cost, and it's just not been addressed, not one iota, not one thing, that it's going to cost us dearly. And the way that a lot of these countries, that a lot of these people propose, like the Canadian healthcare system, which is bankrupt, they don't have they have a system where you really cannot sue for anything. My family's from Toronto. I can tell you how it works. So we have to address the fact that the defensive medicine, defensive documentation, the costs that it takes, it's become so politicized because the trial lawyers have such their talons are such into the political machinations of how things work that unless that's addressed, and with all the other factors, the healthcare bill that's been passed, the healthcare law, is going to fall flat on its face, and we are going to be in dire trouble in the foreseeable future.
Dr. Ruiz?
I agree with a lot of things that have been said here.
Especially the Coachella
Yeah,
stuff?
actually, in fact, I've seen some of you. I thought you looked familiar, actually. So anyhow, I think one of the, taking a step back and look at the big picture of the needs and the healthcare crises that we have in the United States and looking at policy and how it's formed and how it's implemented. The basic value of this healthcare reform was the principle that good health should be for everyone. And I think that both those that sit in the left and right and the center and those that are blue or red or those that are sitting in the classroom here, I believe there's no human being that's going to deny another human being who's suffering the needs that they have. It's just the basic instinct that we have called compassion. And it's wired into our system from day one of our existence. That's the way we survive. Now, so under that premise, we need to improve healthcare access. Let me just back up a little. You said something about, we don't like to wait for our physicians. Well, let's think about the 87% of people, farm workers, in fact, who haven't seen a physician in 4 years. Or let's talk about the individual who I gave free care to at one of the free care events in our hometown who had nocturnal urinary frequency and other symptoms of prostate cancer, and who's had that for the 4 years and hasn't been addressed, and came in with back pain. And so the question of whether it's prostate cancer metastasized to the spine was always asked, and it was difficult to find question. But I believe the way it was politicized was not necessarily focusing on the values per se, because then it became such a far right or far left, throw it down, let's not have it, let's reject it, absolute zero. But I think the true discussion and the true debate should have been in how we're going to pay for it. And have Republicans and Democrats sit together and say, okay, the premise of improving healthcare and creating healthcare reform should be a no-brainer.
I think it is.
And the question is how we're going to pay for it, but not necessarily say, okay, let's not deny healthcare access by just saying, throwing up our gloves and saying, let's not have it. Now, the other question in terms of policy and pushing it forward is, you know, we all know that how politics works. And whenever you have a new presidency, Obama picked the toughest thing he thought could happen, and that's when you can pass your biggest bill. It's your window of opportunity. A new administration comes in, you pick the one shot you can possibly have, and then you push it forward. And that's why it was done in that way. Now, the implementation and a lot of those debates, you know, I understand that we would have liked to have had it fully mapped down to the details, but if you know, in terms of passing a policy with a new administration, if you wait and you wait and you wait, you know, a lot of times it's not going to happen. And if you get bogged down to the details, then there's so many opinions and there's so many different analyses that you can sponsor, so many different think tank groups to persuade whatever you want to have them persuaded towards, that then it's really not going to happen. So the implementation and the details, again, are not fully set. A lot of people are still trying to figure out what the healthcare reform bill actually means. But my question to you and my challenge to you as students is, where do we go from here? Where do we go from here?
It's Thursday night, so they know where they're
Yeah.
going on.
All of us agree that this healthcare reform law is not a fix-all. There's a lot of people still excluded, and there's a lot of needs that need to be addressed. The physician shortage, the physician shortage distribution, the public health education, and the prevention measures that we need to have. So my question is, where do we go from here? We're not waiting in the Coachella Valley for any healthcare reform to solve our problems. We have formed a Coachella Valley Healthcare Initiative. We're looking at the stakeholders, and we're expanding non-traditional stakeholders with businesses, other philanthropists who have not made the connection between health and jobs with healthcare. And we're forming a sort of collaborative to improve our cooperation, not competition, our cooperation, and changing the paradigm so that we can address healthcare for our most vulnerable populations. One of the things I wanted to mention quickly in terms of cooperation and my experience in Haiti was we had the ability to move as a small unit from hospital to hospital. We soon realized that because of the systems were down, because of the frantic nature of healthcare, of humanitarian assistance, everybody's out there trying to save lives. And so the actual communication systems was down, and the time that you had to communicate with each other was down. So we realized in this already poor resource setting, which is Haiti, the poorest country in the Western Hemisphere, that Hospital A had a lot of amputations that were needed. Hospital B, on the other side of the city, had empty operating rooms. And Hospital C had an overflow of volunteer orthopedic surgeons. And if nobody was communicating or cooperating, then you would have a lot of patients who would die from gangrene or serious injuries. And all it took was a simple idea of putting this hospital in touch with this hospital and the orthopedic surgeons and mobilizing them to the appropriate places to save lives.
I want to remind the students that when you talk about Coachella Valley, you're talking about Riverside County, basically from Palm Springs to Indio, in that area with about 500,000, a little bit less than 500,000 people.
Yes.
Okay.
Yes.
Doctor, how did
Let me tell the students that we're going to start letting you ask some questions right after the comment from Dr. Peter Weiss, and then we're going to ask Roger Simon, why was it just inevitable that this debate was going to be politicized? I mean, it just inevitable. Dr. Weiss,
Yeah,
go
I
ahead.
just want to ask a quick question because I'm fascinated by what you did in Haiti, and my hats off to you. It's really impressive. What is it that the Israelis did when we heard of it? They came in and they got down and they set something up that was so well organized and written about that everyone said they were impressed where everyone else was struggling. What is it that they did?
Now, it's very interesting you asked that
Yeah.
because we actually housed the Israelis in our camp.
Yeah.
And they're Israel Aid.
Yeah.
And when they initially went in, they were very well trained in setting up a tent hospital.
Mhm.
And so they just landed in a football, I believe it was a soccer field, and they just set up a hospital and started treating patients, and they were self-sufficient. The other thing, once the initial phase, and this was mostly their trauma coordination team, they came in for about a week and a half, and then they pull out for the second phase of humanitarian assistance, and they bring in other physicians that would stay for a longer period of time in order to debrief the first team. And the organization Israel Aid worked very closely with our organization JPHRO. They were actually camped in our Pessionville camp. And what we all did there too was collaborate in the different needs that we had. One of the things was their capacity to function as a unit was remarkable. And that's part of what I was mentioning in terms of the regional collaborations was that these efforts need to be done in order to increase local capacity. Because if you want to go to vulnerable areas and you're saying, here's the money, but you don't have the internal capacity to even create a strategy or know how to utilize the funds or how to create performance measurements and go back and do that, then in essence, the folks that are silent don't have their voice and don't know how to manage those funds. And it was the same experience in Haiti as well.
From a medical perspective, how is the healthcare crisis in America different than the Haiti crisis? And what I mean by that is when you have an earthquake, a natural disaster, you can mobilize quickly, it's immediate, you see it, it's visual. But in terms of a healthcare crisis, why don't we have that same mobilization? I mean, in terms of the healthcare problems and the deaths that are occurring in America, it's tenfold what happened in Haiti every day.
You know, it's very interesting that you asked that question. In Haiti, you see the needless deaths and the needless sufferings of people that are poor. When it happens in your backyard, then you have the systematic biases, a system that you have to work within that promotes competition. And it really doesn't focus on the coordination or the collaboration. And that's a new model of regional healthcare deliveries where we need to start focusing on. The other issue is changing that paradigm of pooling resources to create a strategy, a regional strategy. So you bring in people that's not saying, okay, it's a free clinic versus federal qualified versus this hospital versus another hospital versus this medical association versus these lawyers versus this education, but looking at our issue as a humanitarian crisis. Because we do have the healthcare crisis in our backyards, in pockets. And you could live in a big city and be lost in a single parent household without any medical care at all and no access to that care. So I think there's a lot of opportunity to learn from those experiences and to draw and to change the paradigm in healthcare for a regional strategies or even start to think of national strategies and even think globally, act locally. Well, you can also think locally and try to extrapolate your lessons learned to a larger model.
Ms. Rodriguez, how is this healthcare bill going to change what you guys do, what free clinics do in Los Angeles on a day-to-day basis, starting tomorrow? Has there been any difference since the bill occurred? It's too early. When will it be implemented? What's your sense of that?
It's too early. We're not going to see any impact
Are you-
till 2014 at the earliest.
So are you preparing for that? Are you, I mean, how,
We're
do
continuing-
donors think, oh, you got all the money now, you don't have to raise money?
No, we're continuing to see the patients we're always seeing. So those that don't have access, that are on public programs. We're seeing more and more patients every day, as I said, because of the slowness of the economic situation to recover. We still are running over a 13% unemployment rate here in Los Angeles County. And as you know, in this country, most people get their health insurance through their work. So as we've seen more people lose their jobs, lose their houses, they're depending on us. So we continue to do that. So in that respect, but it's interesting you bring up the foundations. We have been getting, of course, more questions in terms of how is healthcare reform going to impact the patients you serve and the way you deliver care. One of the things that we are working on with the state is something that's kind of buried within healthcare reform. That's the concept of medical home and providing care in a more organized way. We have always done that, but it's not necessarily been recognized that we do it that way. And so, you know, now it's got to be labeled and it's now going to be certified, that kind of thing. So what we're looking at is what are the things that we'll need to do in order to become eligible for that recognition and certification, those kinds of things. We're also working with the county and their safety net providers to see what we need to do now in order to put the system in place that's needed for effective implementation of healthcare reform.
Why don't we place free clinics across the street from emergency rooms or urgent care across the street from emergency rooms? It's in that people go, I mean, they know that well, actually my son asked me that question, so, and I didn't know the answer, so.
In some cases they are.
Does
Services are
that make a
provided.
difference when they are?
No, services are provided where the population is located. And we have a very dense population here. So it varies from community to community. You know, the needs out in the Coachella Valley are much different than a 6-block radius where you have over 9,000 homeless people. You know, you've got to provide services in a different manner. We actually don't have enough hospitals in this county. We're woefully under, there's not enough hospital beds. So regardless of whether you have insurance or not, you're going to have a problem getting seen and getting a hospital bed.
So I was told in preparing for this that there are actually less hospital beds in LA County, even though our population has increased in the last 10 years.
Oh, absolutely. We've had hospitals closing over the last 10 years at an alarming rate. We have hospitals today in receivership, hospitals for sale. So that's an issue. Our belief is if we locate services by where people need them, that's where we need to be. And in this county, without enough hospitals, we need more clinics.
So you are watching the Urban Lecture Series at Loyola Marymount University, sponsored by the Levy Center for the Study of Los Angeles. We're going to get a couple more comments and then some questions from some students. Go ahead.
So if you look at some communities win from the bill, some communities lose. Look at our local area. So 6 out of the 8 congressional districts are in the worst 20 congressional districts in the sense of having the most number of uninsured and the most numbers of patients on Medicaid in America.
So you're talking about here in Los Angeles County?
Yeah, so from here, make a circle, and if you look at the 8 congressional districts that are what we would call the LA Basin, north of here, south of here, east of here, and a little tiny bit of west of here. If you include those all, including the congressional district we're in, 6 out of 8 are in the worst 20, meaning they have the most number of uninsured patients as well as the most number of patients on Medicaid, which in a state like California, which for all intents and purposes doesn't have money. So any state that is economically having a hard time, and any district or city or county that has the most number of uninsured is going to lose in this healthcare bill. So Indiana or Missouri or Massachusetts or Rhode Island are big winners from this bill. But LA itself loses big because of the fact that we have more people who are currently poor. The other thing is there are some issues that are federal and some issues that are local The issue of the undocumented American, we have 3 million undocumented Americans in California. They have 30,000 in the whole state of Missouri. There's no money in the bill for the undocumented American. So as a physician, I'll treat everybody. As a physician, he'll treat everyone. In fact, federal law mandates, if you come to an emergency room, that you have to treat them. So if you remember when Joe Wilson so rudely interrupted the president in the joint session and said, "You lie," well, the President of the United States was fibbing a little tiny bit. Because even though this...
He should have said, "You fibbed."
Or maybe he should be polite and then afterwards gone out and talked to the media and say, wait a minute, the president's not being totally truthful with us, because the fact of the matter is any state or city or county that has more undocumented are going to have to come up with the money, but there's no money in the bill to do it. So we took a federal problem and we put it very local. And that's going to really hurt Los Angeles, unfortunately. And it goes back to what they were saying about manipulating the discussion and the debate. The correct debate wasn't how rude Joe Wilson was. It was, isn't it a responsibility for American people to take care of the brothers and sisters who live down the block?
Let's get our first question from a student over here.
Okay, I'm Hanif. I'm a senior economics major, and I actually have 3 questions, but they're really simple, all of them. All right, Dr.
Okay.
Ruiz, you mentioned how there's a big shortage of physicians to the public, and I want to know, who do you think is most accountable for that, and what do you think is the best solution for that problem?
Who do I think is most accountable? I think we are as a society, and I think the market is as well. When you have a person who goes through, let's say, 4 years of college and develops video games and can make millions right away, I think that's a more lucrative field than if you have a lot of personal sacrifice, lots of nights without sleeping, a lot of hunger pains for 12 years so that you can help and relieve other people's suffering. So one is a cultural change that we need to have in our society and placing values where they should be. The other is, in terms of the shortage, we have a shortage of primary care physicians. And that's another issue that we need to address, is because the more lucrative fields get paid a lot more. So we have, at some points, general pediatricians making $80,000, $90,000, and you have a dermatologist making sometimes over $300,000. So we have to address that market aspect, and one of the plans is to increase the pay rate for general physicians, which is one thing. The other thing I thought was a very a fabulous idea, which has been done in the past in terms of forgiving loans for physicians who work in underserved areas that they're assigned to, or they have 3 that they can choose from. That's another method that has been used, and that we can pursue that further. And
but then
The bill has money to
And the
increase
bill
that.
has money to increase that too.
Yeah, but then we get all the inexperienced doctors at the underserved areas.
Yeah, that's one aspect. That's one criticism from that as
It's
well.
not a criticism, it's just that, that's
No,
just
but-
one of the aspects of it.
Yeah, but we have to talk again about, I use the analogy of, and I would like world peace. There are certain things in
Yeah.
life that are reality that, when you have a patient that comes to you, or emergency room, or what Dr. Mandel and I talk about, if somebody has, God forbid, a cancer, I don't sugarcoat it. Tell them, this is
Yeah.
what you have, this is what we can do, here's your treatment plans, and this is what we can expect. So there is not going to be this all equal, everyone gets the same. I did this op-ed piece for Pajamas Media, where I basically said, all right, Mr. President, you win. If you want to do everything equal, this is, and was very sarcastic, I must admit, is that every 15 minutes I'll see a patient, and only every 15 minutes, and the patient with hemorrhoids has the same time as the patient with cancer. But that's not reality. You spend the time where you can. But one of the proposals that I had, what you said, is that instead of just forgiving the loans, you make all the state schools straight from high school, 5-6 year program. I don't want to admit that my years at University of Detroit, which was a great school, did not really, I was an art major actually, so it didn't really go that far. You can go straight into medical school. The average student loans are between $200,000 to $250,000 to go through medicine. And it's 12 years of training where you really don't get, for 8 years you get paid really nothing, and then 4 years you get paid minimal. And to do what? Now to be told what to do. We're no longer allowed to be clinicians and make decisions. We've given mandates of what to provide. But if we had a program where it was a state-funded schools, they're for free, and you finish up your training and then you come back as a primary care for 2 or 3 years, yes, you're right. You don't have the experience of the 20 or 30 years that we have now, but you are getting health care.
Dr.
And-
Ruiz?
Yeah, let me give you a very specific example of how the region where I'm from is trying to solve that particular problem. The UC Riverside School of Medicine that they plan to open in 2012 or 2014, depending on funding, is in their mission, they have the focus of creating a diverse student body in order to serve in the area, because we know that the Inland Empire with the Imperial Valley and the Eastern Coachella Valley, Eastern Riverside County is one of the worst healthcare access indices in the entire state. In fact, their levels of poverty is the worst. So the UCR School of Medicine's focus is one aspect. The other is creating pipeline programs. Now, it would be wonderful if we could have their education paid for, but this pipeline program starts in high schools where they have health academies, where they go off to college, they come back for leadership position and trainings, so they go to the School of Medicine at that point, and then from then create a focus of community health and service. And that's something that I'm very pleased with in that regards. And then work it there now. The financial aspect will definitely be a game changer in terms of the market and the values and the interest that the students have in choosing where they practice and what specialty. So that's a very excellent idea.
Ms. Rodriguez?
Actually, one of the other things kind of hidden in the bill is more funding for area health education centers, which do the pipeline programs. And we are one of those area health education centers. But those mentor programs and those pipeline programs are very, very valuable and are a way of doing that. And if you will recall, the last time we had a shortage of primary care physicians, they did do exactly what you said. There were accelerated programs. I was actually in one. So
Why
it's
were they
been done, but then they abandoned them.
Why?
I think due to state, many of these schools are state budget funded, and there then became this cap on slots in training schools. And it's why we have the issues with nursing as well. All of these schools have hundreds of applications for every one slot that they have. And so when you have that kind of competition for a slot, and it's being capped by the systems within the states, you're going to have a problem because it's based on budget, not on demand.
Dr. Mandel, Dr. Ruiz, Ms. Rodriguez, Mr. Simon, Dr. Weiss, thank you for coming to Loyola Marymount University.
Thank you.